Anita Aula, stylist of recycled plastic bags, New Delhi, India. Municipal trash collection does not exist in New Delhi, so millions of unauthorized dumping sites are scattered throughout the city.
As you can see, the plastic really looks nice and it's got a lot of colors. So I thought, why don't we use this as a raw material?
In 2004, this artist and writer created the ONG Conserve India. Her ambition? Make handbags from unwanted used plastic and give work to the city's poorest residents.
When I see a dirty plastic bag, I know in 10 minutes I can wash it and it can really become sparkling clean. So for me, it's not really a huge pile of rubbish. For me, it is just something which the city has not understood yet.
Once washed and sorted, these plastic bags are melted to produce a one-of-a-kind material, the recipe for which is fiercely guarded by Anita and her husband.
So we don't use artificial colors or dyes. The colors that you see are coming from the bags themselves.
Like this is a green and a blue. When you mix it, you get this darker tone.
Last step, making the handbags.
And it really gives a leather
Every
look.
month, 6,000 to 8,000 pieces are exported. A commercial success that has changed the life of some 300 people without legal status who would otherwise survive by scavenging.
My name is Anshu Gupta, and I initiated this organization called Gunj in 1998. We work on a very basic issue of clothing. It's something like out of 3 basic needs where you say food, cloth and shelter, we target the clothing part. We raise a lot of awareness and talk to people about the concept, organize number of collection drives and awareness camps and all. And as a result, we get a lot of material on a regular basis. Then the entire material comes to this store and these ladies actually segregate it. Every single thing is sorted out in a different manner. Anything which is not usable, if it is repairable, we'll repair it, then it will be utilized. But even there is a cloth which we cannot use for anything, we convert into different products. So what she's doing is that she's basically making this for a school bag. This becomes the cover of the bag, this becomes the pocket, and this is basically to hold the bag, the strips. This is absolutely perfect, ready to move school bag. Yeah. This will be used as a rope like this, and once you utilize this particular material, which is the last inch of wastage actually, and you weave it in this loop and make a product like this. This is basically, the waste sheets which we collect. This is like A4 sheets, which is a massive wastage in corporates and photocopy shops, schools, everywhere you waste these sheets. What we say that why can't we use the other side of it? Every 25 sheets, if you waste a notebook. Anything and everything under the sun which is an urban wastage can be reutilized, reused. It might be computers, it might be furniture, it might be school material, utensils, footwear, but the primary issue has been the clothing issue. When you talk about clothing per se, either you talk about cloth bank, which a few cities have, or you literally wait for a disaster to happen, then you take out clothing. So our basic issue was that half the country in any case does not need a disaster, but they need clothing. For every single person who does not have enough to cover himself or herself, winters are much bigger, regular disasters. You can survive without food maybe for a day, but what about the basics? In these cities where you are holding so much, Why can't we look at one women's suit, which is a very traditional and commonly used cloth in India, and if you hold it in your cupboards, you are holding about 20 sanitary napkins for people. We do nothing except cutting that in pieces and providing it to people after properly washing and all that thing. And it becomes a good sanitary napkin for them. And the solution is an old cloth lying in your cupboard. This is what I always repeat, lying in your cupboard. You go back to your place, you open your almirah, you will at least find 20 cloths which you haven't used for the last 3 years, 2 years, 1 year. You don't need it, but you're holding it.
Bihar in India's Ganges plain. In many of these poor rural areas, little has changed in decades. Electricity has been slow to arrive here. Candles and kerosene lamps are the only source of light, but in these straw homes, that means there's a constant threat of fire. But change is coming. Local power generating plants and distribution systems, each supplying about 500 households, are opening up at a rapid rate. Husk Power Systems was founded by Ganesh Pandey.
We set up a couple of plants and we figured that out. Once we got the technology working, we basically started working on the exact business model, the pricing and everything.
The system is village scale. The plants and overhead cables can be set up quickly and cheaply.
When you form one big station and you put out one big grid, then it just becomes a complex operation. The way to provide electricity to rural areas has to be through a small organization.
The fuel for the power plants is a plentiful resource in Bihar. Rice husk. The farmers bring their rice to the millers, where the grain and the husk are separated. The farmers take away the grain. The husk is now collected and sold to Husk Power Systems. It's a handy boost to the millers' incomes. The electricity produced is almost zero carbon, because otherwise the rice husk would simply have rotted, producing CO2.
This is where we put the husk into the gasifier. The gas from the burning process feeds through these pipes and is cleaned by the filters. It eventually reaches the engine, where the gas is used to generate electricity.
Husk Power Systems insists on rigorous health and safety procedures for their staff. The machinery is checked on a daily basis. Regular maintenance is vital to ensure a reliable supply of electricity to their customers. Data on every plant's performance is collected and sent to head office. The voltage and current can be monitored on the company's website. Fees are collected from customers each month, and any faults can be checked at the same time. Customers are trained to use electricity and have to sign an agreement saying they will follow safety rules. Now, when a power plant starts up in the afternoon, people's lives are transformed. Manish is enjoying the benefits it has brought to his family.
Now I feel elated when I see my kids studying at night. I used to struggle to see what on earth I was reading when it was just a lantern. Another good thing is that snakes are frightened away by the light, so bites are much rarer.
बहुत ज़्यादा वो हुआ है लगभग प्लांट के आने से कुछ दिन पहले ही मोबाइल आया था.
Before electricity, we used to go 20 kilometers just to recharge our mobiles, and it cost 15 to 20 rupees.
हमको यहाँ से 20 किलोमीटर दूर जाना पड़ता था.
Where power plants have started up, new shops and businesses have quickly followed. Power after dark means they can trade into the evening. People gather to talk, eat and buy goods. And the cost of a power connection is reasonable, starting from about $2 a month. Husk Power Systems also helps local people get the skills they need to run the power plants and earn higher incomes.
We have a very extensive training program which basically takes people from these rural areas, unskilled people, sometimes with very marginal or even no education at all, and converts them into skilled or semi-skilled workers.
And there are other benefits. The waste from the gasifier is a black ash, which these women use to make incense sticks.
Before the plant, my husband was the breadwinner. Now I contribute to the household, and that makes me happy. My husband used to buy my clothes, but now I buy my own.
Our future plans are to take our approach worldwide, and by 2014 we plan to have 2014 decentralized generation and distribution systems worldwide.
Before electricity, we didn't know which century we were living in, but now we feel part of the modern era.
It started with one man and his dream: to prevent unnecessary blindness and restore eyesight to millions of his countrymen and women. When Dr. Govindappa Venkataswamy started Aravind Eye Hospital in the Indian city of Madurai in 1976, it had 11 beds. Today it has clinics and hospitals throughout India and is the largest cataract facility in the world. Dr. Venkataswamy passed away in 2006, but his work lives on. The evidence: tens of thousands of Indians who have been given back the gift of sight.
Blindness is one form of human suffering, but it is beyond just disability. So because it takes away the mode of living for a person, and also takes away their self-esteem, and also brings down their stature in the community. And we have a large number of people in India, about 12 million people are blind in our country, and equally a significant number of them are children. But the good news is that 80% of this is curable. A simple cataract surgery that takes maybe like 7-8 minutes can restore the vision for about 7.5 million people. Whereas a pair of spectacles can give the vision for about another close to 2 million plus people. But however, the people who belong to this, who are blind, belong to a poor socioeconomic group where the literacy level is very low and the healthcare awareness is also very low. And they all live on daily wages, so, and as a result their affordability is also quite poor. And the day-to-day living is quite a challenge for them. So it is in this background Dr. G. Venkataswamy, who is the founder of this organization, he started this hospital in 1976. After his retirement from a government hospital where he was a professor of ophthalmology heading the ophthalmology unit, doing a lot of community-based eye care work with the government. See, on retirement he felt that government alone may not be able to solve this problem of the health care, especially eye care, which is needed by a large part of the community. Hence he set up a non-governmental organization to take over the work he was doing all his lifetime. But however, there were some challenges when you want to provide eye care or health care through a non-governmental organization. We have a problem in creating access for the people and also for us to reach those people in the rural area. And To making it affordable both for the patient and also for the organization is another challenge. And ensuring a quality when you want to do high volume of work is another challenge. And the biggest challenge is that there was a scarce capital and also human resources at that point of time. But however, he had a lot of experience, so he involved a lot of community-based organizations like Lions or Rotary Club to take this eye care, help him to take the eye care to the rural area. He engaged them to do the publicity, fix up a place for conducting the camp. They also provided volunteers. The nurses, in turn, took care of checking the vision, and the doctors did the examination at one point. At two stages we do the examination by the doctors. The nurses also take care of refraction, checking for the glasses. They get their intraocular pressure is checked to rule out whether they have glaucoma or not. With all the details, the doctor does a final examination, gives an advice whether the patient needs a surgery or he needs a glass or needs just a medication. So if the patient needs surgery, the very same day we transport them by a bus to our base hospital. So this is a model where we do screening in the villages and do the surgery in the hospital. So the patient gets a free surgery, the food is also free, and also transportation is free for these patients. They normally stay with us for about 2 to 3 days depending upon the distance from which they come, because they may not be able to come back, and most of the complications happen within the 48 to 72 hours. And after they stay for about 2 or 3 days, they go back, and we send a follow-up team to the place after a month to see these patients and provide the necessary medication and the glasses. The last year alone, we conducted over 2,400 such camps through all our hospitals. We have a network of about 7 hospitals. We screened about 860,000 patients, and 76,000 patients were taken back to the hospital for surgery. But this number may seem very impressive, the way to do it, but when we looked at the people who really got the benefit, who need a care but came to the eye camp, was only 7%. So this study we did with the London School of Public Health. So based on the findings we had, we created a permanent eye care centers in the rural areas, using only the technicians, covering a population of about 50,000. So when you don't have a doctor, which may not be very cost effective, you have a challenge of making a comprehensive eye examination. And also there's a question of ensuring quality in terms of making the right diagnosis and prescription. So we came up with the idea of having an electronic medical record in these centers with image integration. We also had broadband internet connectivity or a low-cost Wi-Fi connectivity wherever it was not existing, to connect these vision centers or the primary eye care centers with the base hospital, where a doctor will be always available from the morning to evening to consult with the patients and with the technicians. So this is what you will see here. One of the technicians does all the registration part of it. The other nurse does all the refraction, checks the intraocular pressure, and uses a digital camera. If we have to take a picture, we use that camera, which costs only about 6,000 rupees, to take the pictures and load them. Then subsequently the doctor interacts, sees all the data, interacts with the patient, interacts with the nurse, and gives an electronic prescription, which gets printed in the center. So they can get the glasses or some of the common basic medications there. So out of the 100 people who walk into such centers, only 10 of them need to go to the base hospital, either for surgery or for other investigations. So this is one way to create access for these patients. So if you want to create universal access for the people in the community, we need to design services for the non-customer. Non-customer means the patients who are not coming to the fixed permanent healthcare facilities. We need to keep them in mind, their characteristics, and design the services. We also have to make sure that when you do such an kind of initiative, we need to involve the community, and we must have a very robust monitoring system on a daily basis. So because of that need, there is a need in the community, but when we convert them into demand for the community, we have enough work. So over a period of time, we have expanded to about 7 hospitals with 4,000 beds, and we have about 6 outpatient clinics, and we have 39 such vision centers. And these are services we provided last year. We were able to we saw about 2.6 million outpatients through all our centers and also operated about 350,000 patients. Of that, if you see the outpatients were about 48% who received free care, and about 68% of those who underwent cataract surgery either paid a very free or a very steeply subsidized cost. Now, how do we make it affordable? It's not just for the provider, we also need to make it affordable for the patient. So when you look at the cost, when the providers or the doctors, we look at the cost of the providing the service or the product. But when the patient looks at any service, he looks at the access cost, the cost for travel, the time investment because they lose wages because they're not going for their work. And but culturally, someone has to accompany these patients to the hospital. So there is a similar cost incurred by other people also. And if you don't complete all these investigations, or if you ask the patient to come back again for surgery some other time, there is also involved repeat visits. Just an example, I've taken about spectacles. When somebody wants to buy a cheap spectacle, it may cost about 250 rupees, which is like about 3 pounds. But to get that spectacle, for getting it, the person has to spend maybe another 2 or 3 pounds, which means, which is the cost of traveling to the doctor, for ordering the glasses, getting back the glasses, checking it with that. But if you come up with a strategy where if you can take away that cost, so like here, on all our comprehensive examination camps, we also have a mobile optical shop where they take all kinds of frames and also a wide variety of lenses which are semi-finished. So when the patient chooses the particular frame, we can fix those lenses there itself and give it to them. So the whole process of patient walking in, getting the glasses, going back, checking it, they are usually happy. Once they wear it and see, when they're happy, they take back the lenses. Maybe like 10% of the lenses, we may have to take it back, we fix it and bring it back to the village and deliver it at some other point of time. So if you can complete all investigations, when a patient comes to the hospital, you can reduce their cost substantially. Similarly, when somebody comes to the hospital for surgery, if you can admit them immediately for surgery and operate them on the next day, or if you can, and you can eliminate all the unnecessary tests and you can minimize their stay, again, all that will go on to save money for the patients. At the same time, we also need to make sure that the provider, the hospital also remains cost efficient. So we need to look at what are our bottlenecks, manage them, and we should not waste any of our resources. And also we need to ensure high quality, because poor quality is going to cost us more. This is one example, how do we manage. So ophthalmologists or doctors are a very important resource in our country. So we cannot waste their time. So hence, all the tasks that can be done by the paramedical staff are all given to them, so as to maximize the productivity. So the doctor's time is spent mainly for diagnosis, giving the treatment, or performing the surgery. So any kind of a measurement is not done by the physicians in our organization. This is an example. Once we make them productive, how do we really get the best out of them? Here you can see the doctor is operating and another patient is being prepared on the other side. So as he finishes the surgery, so he applies an antiseptic gel, which we have proved that it's quite effective and safe for the patients. He starts the next surgery. So there is a system wherein who will give the block for the patient, who will give the anesthesia, who will take them inside, who will check whether the correct patient has come inside, the draping, everything has been staged and it has been given to one particular person who does it. As a result, we are able to make the doctors also very productive. To make these doctors productive, we also need to employ a large number of the paramedical technicians. Every year we take about 400 girls who have done the 12 years of schooling. They normally do about 2 years of a structured course, and they are usually trained in a particular area so that they can perform that task much more efficiently, much more with better quality, and bring down the cost. As a result, this is the productivity of ophthalmologists in Arvind. They do about 1,700 to about 2,000 surgeries compared to about 300 or 400 elsewhere. And we also need to ensure quality when we have a large volume of these patients, and a large segment of the patients cannot afford, or from the rural areas. So we have a defined clinical protocols for decision making, and also we have standardized our workflow as you have seen in the operating room.